Hello and happy Friday. Welcome to our assisted outpatient treatment community of practice. Thank you all for coming. And if you received our reminder email, you know that today we have Dr. Scott Smith here to give a presentation on the intersection of serious mental illness and substance use disorder. As always, there will be a Q&A portion at the end, so feel free to raise your hand during the presentation, put in the chat, or save it for the end. Before I kick it off and hand it over to Dr. Smith, there's a couple of housekeeping items that I'd like to make you all aware of. So twice a month, we have Dr. Scott Smith available for a drop-in AOT Q&A session. Anyone can come to these sessions with any AOT related questions. It is a drop-in, so you do not have to come on time, but anytime within that hour span. This is also a great resource to share with your families and loved ones of AOT consumers. As AOT gets more attention across the state, more questions are going to arise. So please share this information internally and with community partners you may work with if you're finding you need some guidance around AOT matters. And so I did drop those dates and times for the upcoming Q&A sessions in the chat. So please feel free to refer to that and also take note of it as well. If you have any questions that you do not get addressed today, please be sure to attend one of those Q&A sessions. These are open to anyone and everyone who has a question about AOT. And then the next thing we want to talk about is our AOT Toolkit. I know that most of you are aware of our toolkit and have visited it in the past, but we are constantly adding new resources that we've developed with the help of our experts and community partners. I wanted to take this opportunity here today to show you all some of the new things that we've added. Okay. And so first, we have the notifying the court of non-adherence packet. I'm hoping everyone can see that. And this packet is a helpful resource and guide providing pertinent information regarding to the non-adherence process. It contains a step-by-step instruction on key documents for initiating an order of non-compliance, amending an existing order, example forms pertaining to the non-adherence process, as well as identifying when these forms are required. And so I'll just, quickly browse through this so you all can see. And this is somewhat of a lengthy document, so please take your time in reviewing this and looking over it. Again, this is a very helpful resource and guide for anyone who is seeking more information and guidance throughout this process. Okay, my apologies. And so next we have the mental health glossary for law enforcement. This contains key terms and definitions. This resource is meant to aid in law enforcement officers filling out petitions and other AOT paperwork. This glossary lists common behaviors, moods, and attitudes of those who might be eligible for an AOT and identifies the clinical term associated with them. These terms can be used on an AOT petition. And so this is a one-page document that lists all of those terms as well as the corresponding definitions. So an excellent resource to our law enforcement as well as any other community members who find it pertinent to become knowledgeable about these terms that is used within that law enforcement setting. Okay, and then next we have the system of care roles and restrictions. So this resource is meant to provide a general overview of the roles, restrictions, and information sharing activities for positions that are a part of the AOT system of care. These lists are non-exhaustive and some roles are not represented. And so I will quickly scroll through this as well.
I'm sorry, where do we get a copy of these resources?
These will all be posted to the AOT Toolkit.
Okay, thank you.
Yep. All righty. And then this next document that we have, this is the establishing clear and convincing evidence for AOT. So this resource depicts that the burden of proof in assisted outpatient treatment in cases lies within the petitioner who must provide clear and convincing evidence that the individual meets specific criteria for AOT. This demonstrating the person's mental illness impaired, includes demonstrating person's mental illness impairs their ability to care for themselves or poses a risk to themselves or others, and that they lack insight into their need for treatment. This also includes testimony from psychiatrists who act as expert witnesses, essential to these proceedings, with case managers and treatment team members providing supportive information. This is a clear and detailed providing case notes that which are essential for psychiatrists to effectively present evidence in court. And again, this resource will also be made available to you all on the AOT Toolkit. And last and certainly not least, we have the individual summary for pickup order. This is a resource created by Clinton Eaton Ingham CMH and Lansing PD. It is meant to give law enforcement officers who are executing a pickup order a summary of the individual's history and present demeanor. This summary can assist an officer executing a pickup order in the safest, most effective way possible. And so again, those are just some of the few many resources that we've added in the last couple of months. So please be sure to check the toolkit regularly for new items. And if you have any ideas or feedback on what we could be or what could be a helpful resource to develop, please be sure to let us know. And so without further ado, I will go ahead and pass it over to Dr. Scott Smith. Thank you, Scott.
Thank you very much, Devon. Happy Friday to everyone. I'm excited to have this opportunity. I I feel like we've done a marginal job as a society of really considering the wide ramifications of substance use, and I think unintentionally, with all of the focus on opiates, well deserved, but heavy focus on opiates, we've kind of watched as numerous other substances have crept up. So today, in the short window of time I have, I really want to talk about some of the uh, aspects around the intersection between serious mental illness and substance use disorders that I don't think we've paid enough attention to. And I'm hopefully designing this as a teaser so that uh, you will want more in-depth information on this, especially about methamphetamine and newer synthetic drugs, because I think that that is very much the future that we are looking at with community mental health specifically and with the SMI population, and actually seeing a new generation of individual with classic psychotic features, but that don't respond to medications that are in fact a drug induced and potentially permanent due to neurological damage. So let's get started by talking about some of the trends and what we've been seeing go on with substance use. And I'm going back to 2015 for a couple of reasons. One, puts us at, the 10-year mark. Two, I think that it helps provide a better window. Unfortunately, all the data from, COVID years, so 2020, 2021, really is not as reliable as other data. So by taking a look at things overall, first, the bad news, illicit drug use is on the rise, and not just a little bit. Back in 2015, what we were seeing was about 10.1% of those individuals 12 and older admitted that they had used an illicit drug at some point in the past month. Fast forward to 2023, the most recent year we have data for, and what we see is that that number increased 50%. So now we are seeing 16.8% report that use. Now, I will caution you that this does include marijuana use, but it doesn't explain everything, and I'll get to that in a moment. And what we've known is that historically, people living with a serious mental illness are more than 2.5 times as likely to have used any illicit substance in the past month than those living without an SMI. And this is about 10% higher for people with a serious mental illness versus a regular mental illness. So most of us have been around long enough to know that where there's mental illness, there's a high propensity for self-medication with some type of substance. But part of what we're seeing is that there's something unique about serious mental illness, whether it's the severity of symptoms, whether it's the external ramifications of living with a serious mental illness, such as changes in your community, changes in your function. We know that the risk is just substantially higher within this population. And I know that personally, in my practice, I've always been stymied by the fact that it's very easy to find yourself in a catch-22 where you have somebody that their serious mental illness has reached a point where they're needing hospitalization, but they're also showing positive for multiple substances. And now it's this debate because inpatient hospitals might not want them because, well, this could be drugs. And drug treatment places don't want them if they've got other psychiatric symptoms, especially suicidal behavior. So, this consequence of SMI, the higher rate of both use and substance use disorders, really makes things challenging in terms of treatment planning and continuity of care. Um, I did mention this before, and I want to acknowledge the fact that since 2015, one of the biggest changes nationally that we've seen on the drug front is that marijuana has been legalized in multiple states. And as a result, there's some debate on whether we should still be including this as a illicit drug or separating it out like we do nicotine, alcohol, other substances. But for the time being, that's in there. But what's interesting is when we look at the actual numbers, the increase in marijuana does not explain the overall increase in growth. And part of what we see is that there are other substances that are actually increasing markedly. So, for example, we've seen a doubling, twofold increase in methamphetamine and hallucinogenic slash psychedelic use, right? And again, I'm very, very concerned about the rise of methamphetamine. I lived in Arizona for a period of time. Meth was far more rampant there decades ago than we were seeing in other parts of the country. And I have to tell you, it was the scariest drug. Between what I saw in the ER I worked in, I was doing mobile crisis teams, where there was meth, you had very complex problems. You had a higher rate of aggression and violence. You just had a bad combination. We've also seen that doubling of hallucinogenic psychedelics, and there's a variety of explanations for this, and I'll talk about those in a moment. We've also seen a move away from natural or even prescription opiates to more of the synthetic opiates, especially fentanyl and designer fentanyls, as we often call them. And a big trend towards synthetic drug use overall. And what gets really challenging is that it's hard to collect good data on synthetic drugs because we don't have a great way to test for them. In fact, most of them, you would have to develop a specialized test for that specific substance. Also, many of them end up being in a legal limbo where they're not legal, but they're not illegal. And until, the DEA catches up, very often these drugs can be widely available. Some of you are old enough to remember when the synthetic drugs, like bath salts, K2, Spice, were showing up. They were first being sold in like gas stations, right? And so we've seen that go way back, late 80s, early 90s. You can see the same thing happening with ecstasy. So many times these synthetic drugs are making the rounds. They're not part of our normal screening. People don't report them even as necessarily drugs in the same way that they don't report over-the-counter medications as, taking medications or using drugs too. And when we take a look kind of at this data overall, part of what we're seeing is that there's been a pretty steady number out there that half of everybody living with a serious mental illness has a co-occurring substance use disorder. But we know that all of these numbers are prone to dramatic underreporting. And there's been actually a lot of criticism of this. So, for example, one of the things that happens is we exclude individuals who are unhoused or even have unstable housing if they were incarcerated or if they were hospitalized. So I don't think we're getting a very accurate portrait at all. So we should probably look at these numbers as the best case scenario. The best case scenario is at least half of our clients with serious mental illness have a substance use disorder. And I think anecdotally, we know that it's probably much higher. And I want to kind of switch and talk about specifically psychotic symptoms and their relation to substance use, because I think psychotic symptoms in general are not something that most of us get a lot of great training in, at least at the graduate level. Most of what we learn is on the job. And what I've noticed is that we have opportunity for growth here. I think that we've kind of failed overall to do a good job of recognizing the early symptoms of psychotic disorders, the ones that often emerge as what we call the negative symptoms, that is, the things that are taken away versus the positive symptoms, those things that are added. Added would include things like hallucinations and delusions. Taken away would include things like anhedonia, uh, poverty of speech, things like that. And those are, by the way, the symptoms that are more likely to kind of be present for a while as somebody is kind of growing into a serious mental illness like schizophrenia, like bipolar 1. And very often the consequence is we wait until there are very overt symptoms that usually results in an involuntary hospitalization. And that process has been heavily attributed to the delay in care for psychotic disorders. And on the other side of that is the fact that we have so few beds in Michigan overall that we can't risk hospitalizing somebody simply because they're having a psychotic episode if it was drug induced. And I know in the ERs I've worked in, I usually have to fight pretty hard to try to stop, an admission or sometimes even stop a ER doctor from writing schizophrenia in somebody's chart who appeared and had just done a ton of blow over the weekend. And fighting to really try to get things slowed down. Like, let's give this 12 hours, let's give us a day of observation before we go to this next level. So, what we know about psychosis and substance use is that psychosis can occur from virtually all of the illicit substances that are out there. In addition to that, alcohol, especially chronic alcohol abuse, does produce psychotic symptoms over time. Misuse of over-the-counter medications as well as prescription medications are obviously pretty significant contributors as well. And I think that this is especially important because what we see is, especially for younger people, it's these over-the-counter medications. I went on the interwebs and heard you could get really messed up if you take a bunch of Benadryl. And then that kind of actually works in more of a gateway function, leading them to more and more use. Now, it's worth noting that this might be an unsolvable debate in terms of the relationship between psychotic disorder, bipolar disorder, and substances. Um, there's some evidence that suggests it's very causative. There's other evidence that suggests that no, it's these early associated symptoms that result in need for more self-medication. But there's a strong relationship, whatever the direction is occurring. And focusing for a moment on that idea that substance use may occur to self-medicate early symptoms. One thing I've found, especially among psychiatrists, is that it might be because most of the psychiatrists I interact with are close to retirement. I'll put it that way. And they have real big feelings about marijuana, and they have them without necessarily regard for a variety of factors. In fact, the data that we got all those stats from It's just recently that they've started asking specifically for those who report using marijuana, what was the mode of administration, right? So were you doing waxes and dabs? Were you um, vaping? Because it matters a lot. And what I've heard more and more recently is that marijuana is the number one drug of concern because we see a lot of individuals with mental illness, especially serious mental illness, who smoke marijuana. And I'm not yet ready to jump on board with that idea, but it's a very widely accepted premise within the psychiatry community right now. So among psychiatrists, what I think we're not addressing with that or really paying attention to is that very often that substance use was to medicate those early symptoms, the agitation, the heightened anxiety, the low mood. And if somebody's smoking marijuana, that's telling us something very different than if they're using waxes, oils, things that we know are actually very easy to result in a psychotic episode. And yet at the same time, there's plenty of evidence to suggest that there are a variety of substances that can hasten or precipitate the onset of a serious mental illness for somebody who has that type of genetic or environmental vulnerability. In fact, we know that this happens for a lot of people living with bipolar disorder when they treat their depression. If their prescriber doesn't do a good family history, if there's unknown family history, we know that the danger is giving somebody a monotherapy, like just an SSRI for depression. If they have a propensity for bipolar disorder, that can actually cause that first break. And part of the reason that that happens is that serotonin is one of what we call the essential monoamines. And these are very chemically similar neurotransmitters that can use other transmitters' pathways. And I'm not going to go super nerdy on you today because everybody warned me not to, but in some point, we're going to get all the way down with my nerd. But what I'll say is that that's relevant to us because there's only one drug out there that easily mimics these monoamines like serotonin, norepinephrine, dopamine, and that's methamphetamine. So say that, we'll come back to it a little bit later. Now, this can precipitate. And in fact, what we've seen very often is somebody uses meth, they use crack, and they end up having a prolonged psychotic episode. And then we see, even without use, these psychotic symptoms reappear and start to notice the pattern that we look for when we're making a schizophrenia diagnosis. And this creates a bigger problem for us as clinicians because it's hard to know what we're really dealing with. So if somebody is using, let's say, crack and has a diagnosis of schizophrenia, we can't evaluate medication effectiveness even if they're taking it because the crack is going to negate a lot of the effectiveness of that medication. We can't evaluate whether we're seeing actual remission of symptoms, whether we're actually, seeing a prodromal period because maybe they were a low prodromal, but they smoked some crack and now they're in that acute phase. So it makes it really difficult and also makes it difficult to treat. Like I already mentioned, we've all had that experience of somebody being too mentally ill for substance use treatment and having too much of a substance problem for psychiatric treatment. And despite a few places still advertising themselves as having co-occurring programs, I tend to think that that's just they haven't updated their marketing materials in a while because I don't really see a whole lot of places that are taking true co-occurring cases, and that is half of our population. So, what is the kind of risk contribution, or what are the factors in a way that influence how much risk for psychosis can come from a substance? Well, the first thing we want to be aware of is that mode of delivery matters. And this is why I'm glad to see that we're finally in these nationally representative surveys asking better questions about like mode of administration. Because if you're smoking something versus shooting something versus ingesting something, that all matters. And what we generally see with psychosis is that in terms of mode of delivery, the faster the onset, the greater the risk. So the fastest onset we know is when we smoke something, especially when we've heated it to chemically free its base, the ability to permeate the blood-brain barrier very fast, followed by injecting something. Those are the two fastest ways. Well, this creates not only a rapid change neurologically that's going to require some adaptation and over time can result in the expectation of those substances, similar to what we see with alcohol use, right? We go through withdrawal because the brain adjusts and says, well, if you're going to drink all the time, then we're going to produce far less GABA. We're going to produce far less glutamate. And that's why when somebody kind of cold turkey stops, goes into withdrawals, they're at a big risk for seizures. So, faster onset has that potential to kind of change our brain and get our brain accustomed to this change so that it functionally changes. The additional piece there is that the behavioral cues are much stronger. So the faster something works, the greater propensity we have for developing that psychological dependence, right? And this is why, we're a little bit more concerned about prescribing Xanax than maybe Klonopin, right? Just having that slightly longer, like, onset period dramatically reduces the likelihood of developing a problematic behavior. Whereas when you grow accustomed to something working immediately, it's much easier at first to psychologically depend on that. The form of the substance also matters a lot, right? So, for example, the effect of cocaine varies whether it's in powder form or crack form, not only because of how we're ingesting it or taking it into our system, but also because of what chemically changes about the substance. And that change can be enough to both increase the speed of onset and the intensity of that euphoria, that rush. Smoking marijuana versus using those waxes. What we see in terms of the biggest danger tends to be when you have a very, very high concentration of THC, such as we see in vapes, such as we see in waxes and dabs, such as we can inadvertently see in edibles. And, something we've seen in ERs across the country now since we started having legalized marijuana are people who suddenly are like, oh, I would very much like to try this. And I think I'll try an edible. And apparently nobody warns them that you don't eat the whole brownie. You have a small bite, and you wait, and it might take a longer period of time for it to kick in. And absent that, what we see is people sometimes just eating the whole brownie, think that's what you're supposed to do, or they eat a little, 10 minutes later, no effect. They eat a little bit more, 10 minutes later, no effect. And pretty soon they've reached a very, very high concentration and they are having psychotic features. We've also seen this, unfortunately, occur accidentally. I probably shouldn't laugh, but I'm going to anyway. Had this older woman, her husband had actually purchased some THC gummy bears, he had some chronic pain. He actually had a medical marijuana card. But he didn't do a good job of communicating with his wife that, oh, hey, these are not normal gummy bears. So she saw them and ended up eating one of the little bags full of them. And then the fun started. So when she came into the ER, she was hyperverbal, she was hallucinating, seemed to be having an overall good time, but definitely, there was some concern given her age that this was delirium. I actually, my intervention, once we confirmed the cause, was to put her next to an intoxicated guy who was also very chatty, and they just chatted with and at each other for about 12 hours. So that was a good intervention. And those of you who have crisis stabilization units, try that one out. It can often fill the gap in terms of our interventions. And then obviously, dose is a big deal. I love this quote from Pericles. All things are poison, and nothing is without poison. The dosage alone makes it so a thing is not a poison. And what we know is that literally any substance can be toxic or have a negative effect in sufficient quantities. And what gets even more interesting is when we look at some of the emerging substances that aren't yet maybe controlled, but are showing concerning trends. A great example here would be kratom. For those of you unfamiliar, kratom actually is a plant-based supplement, usually marketed as like a sports or nutrition supplement and sold in like powder forms. You'll also see it sold at like vape shops, which probably gives you some idea of what its broader intended use really is. And it's worth noting in the Southeast Asian countries where kratom grows wildly, it is outlawed. But we haven't done it yet here. And the interesting thing about kratom is that at certain doses, it has analgesic like effects. And at other doses, it has stimulant like effects. And there's even been treatment centers that have looked at using, the analgesic type dosing to help individuals who are withdrawing from opiates. Uh, I just use this as an example because virtually every substance out there could potentially have some therapeutic benefits. Uh, Cocaine is a form of amphetamine, slightly different from things like lisdextrofenamine or Vyvanse, the most commonly prescribed ADHD medication. When it's prescribed and the dose is controlled, it can have very healing properties for individuals living with ADHD, including the one talking to you now. But at high doses, toxic, even fatal. Interesting story here. There are researchers now that are actually looking at how methamphetamine can be used to help traumatic brain injury patients, specifically because of meth's ability to permeate the blood-brain barrier. And those of you who have been practicing as long or longer than I have probably have seen a few times in your life, or might even remember when we actually prescribed methamphetamine for the treatment of not only ADHD, but also in short-term like dosing for obesity. So it's important to remember that the dosage, the amount really makes a big deal. And this is important because a lot of times when we're having debates around the use of like certain psychedelics for treating things like treatment-resistant depression or treating various trauma-related symptoms, it's all about dose and not just the amount you're taking in, but the frequency that you're taking it. That's what changes it. And this is a nuance that unfortunately gets lost and leads people to be absolutists and say, always good, always bad. And then we run into the problem that uh, it's really hard to tell the difference between somebody experiencing a drug-induced psychosis and psychosis that occurs as a natural symptom of like an organic mental illness. And I want to play part of a clip. This is actually archive footage from the Veterans Affairs, the VA, that was part of their early research on LSD. This is, I assure you, a real video. And I will apologize ahead of time for the fact that the individual doctor administering it and talking to the participant has a super creepy vibe. So I just will acknowledge that. And I'll just play a little bit of this video, but you'll have this access to this PowerPoint later on.
Can we turn up the volume, Scott?
All right. Well, I thought that that would uh, work better than it did. I apologize. I don't know why that doesn't want to um, actually play the audio better for you, but I'm going to go ahead and just move past that. Be sure to watch that a little bit later, though, because it is both entertaining and I think deeply troubling to see the behavior of that psychiatrist involved. But the point I was making uh, with that is and I'm sorry, is the screen sharing paused as well? That's awesome. Okay, hold on. That was a colossal fail. My apologies. All right. Screen should be able to see now. Everybody. Okay. So one of the challenges is that if we don't have kind of an opportunity to observe somebody kind of with their symptoms. By the time we see somebody who's acutely psychotic, that acute phase, whether it was initiated by, a psychoactive substance or by the organic process, is virtually indistinguishable from the other. And this is an important consideration because, again, we're assessing somebody in a moment in time. And I see far too often where we place very big diagnostic labels on a snapshot. And don't get me started on the fact that I think we rush to a serious mental illness diagnosis a little bit too quickly sometimes. That's another community of practice topic for another day. So let's kind of spend a little time on the growing drugs of concern with our few remaining minutes. And what I want to say is kind of similar to what I mentioned earlier. You know, we've been really focusing on opiates to the point where it seems that everybody believes that that was the only problem we ever had. And while it was obviously deeply concerning, all of the attention on opiates hasn't really kept up with the fact that a lot of our interventions have worked. A lot of our restricting of really handing out, prescription opiates has worked in terms of reducing opioid use. But unfortunately, something that many people outside of our world fail to understand is when somebody loses access to their drug of choice, they don't usually just say, well, I guess I might as well just get sober and stay sober. Very often we see a shift, a jump, an evolution. And I think that that's partially what explains the increase in use of some of the other substances is that it has been a little bit harder to come by, the traditional opiates that were being abused, and now we're doing other things. So I want to start first with the increase in hallucinogenics, psychedelics, and we're seeing a big resurgence of these. And a lot of this might actually be influenced by all of the information out there on how these psychedelics might actually have healing properties or might have mind expanding utility that is not necessarily pathological, right? And we know that this continues to be a hurdle to actually get quality treatment for people where this might be helpful. But unfortunately, I think a lot of people now make the assumption that it's inherently safe. And it's worth reminding ourselves that the reason that this class of drug is called hallucinogens is that, well, their primary effect is hallucinations. So whether it's shrooms, whether it's LSD, or some of the newer emerging uh, hallucinogenic psychedelics, um, that is their primary symptom presentation. So I think that it's an important, differential diagnosis. And remember, a lot of these are not very easy to test for, especially in our 7-9 panel urine drug screens. Now, what we know is that many of these drugs are much safer than we maybe historically have assumed, but they vary greatly from one drug to another in terms of notably their long-term risk. We do see long-term evidence of brain changes. In fact, it's some of that brain change that we try to harness with microdosing and other things to treat certain disorders. What we know to be generally problematic is when we see high dosages and chronic use. That's really where the big problems come from. We also know that some of the drugs don't completely metabolize during use. great example of this is LSD and the potential for flashbacks. I had a case a few years ago where an individual came in acutely psychotic, but he was in his late 30s. He didn't have the profile of somebody with a traditional psychotic disorder, even though the ER docs were convinced this is, schizophrenia. He was outside of that critical window of onset. And from the reports I got from family, from friends, this happened really suddenly. And with a little bit more like questioning, what I found out is that he had been in a minor accident. He actually fell at work from a ladder, bumped his head, no loss of consciousness, didn't seek any medical treatment. But we've got case studies showing that the LSD that was not actually metabolized might just sit there in our cerebral spinal fluid, in our meningeal, tissue even, and that sometimes it can reappear without warning, especially if there's some type of like minor head injury. So it's again something to be mindful of and just to monitor for the potential that it could continue to make an appearance and be part of what we have to differentiate when we're making our assessments. I also want to spend a little time talking about over-the-counter anticholinergic drugs. And this, by the way, will include drugs like Benadryl or Robitussin DM. What we know is that at high doses, most anticholinergic medications, and that's a big class of medications and includes, among other things, SSRIs to some degree, that they can cause hallucinations at high doses, or what we should more specifically call toxic doses. And a lot of younger people are actually utilizing them for that way. You can buy them over the counter, which gives a presumption of safety. And I've actually seen in my practice a lot of confusion sometimes where the assumption was if you took, you know, 2 boxes of Benadryl, you were trying to complete suicide, when in fact you were just trying to get high. So I always think it's good in our suicide screenings to make sure that we're ruling out the possibility that they ingested a large quantity because they wanted to get high. And this includes a large quantity of anything, because go online and you'll find somebody who will tell you that anything will get you high. And the easy access not only gives them this sense of safety, but it makes it concerning because it's hard to monitor, it's hard to regulate. It doesn't flag with family members that, like, oh, hey, why are you going through a box of Benadryl, 3 times a week, right? So I think this is something that it's also worth asking more specifically about when we're talking to our clients, doing an assessment, because sometimes that gets omitted. And what we know is that long-term abuse of anticholinergics is associated with neurological change. And notably, there's some increased risk for dementia. Then we have the synthetic drugs, also known as new psychoactive substances, or NPSs. And these are growing in popularity both because they're much more readily available because they can be manufactured locally, and also they are difficult to detect. And that difficulty in detection is especially beneficial for somebody who has to submit to regular drug screenings, those on probation, participating in a mental health or substance use court, those who have substance training or testing written into their AOT. Um, Include things like K2 spice, even fentanyl and its many designer variations, bath salts. And the scary thing here is that they're incredibly unpredictable, a lot of hidden dangers, and they become really difficult to study because uh, we often only encounter somebody that's used them when they're in an acute state, and we don't recognize it's the direct effect of an underlying substance. So what we really have to rely on is the combination of both physical and psychiatric symptoms and any patterns we recognize. And to that end, I just want to highlight 2 great websites that I think are worth checking pretty regularly. The first is the NDU, or the National Drug Early Warning System, out of the University of Maryland. They do a great job of trying to get out information on when they see variants in certain drugs, when they're seeing new drugs emerge, and they create opportunities for you to share and report, to try to get clinicians around the country and even globally to kind of stay one step ahead of a lot of these challenges. And the other one is the Drug Abuse Warning Network, DAWN. And they're primarily the data collectors, division of SAMHSA, but they work with ERs to try to look for trends, and then they'll report on them. They'll report when new drugs are emerging. It's how back in, I think it was 2012-ish, we started getting warnings about a synthetic opiate called crocodile that was resulting in, actual like massive like flesh-eating responses at the injection site. And then we have methamphetamine, which I've talked about a little bit, and I know we're out of time, but I want to highlight a couple of key concerns. One is I don't think we're paying really any attention to it. Secondly, there are drugs that increase dopamine, and there's meth, and nothing comes close to it. And since dopamine is the primary neurotransmitter involved in psychosis, it's a big deal. And it not only floods our brain with dopamine, but it also blocks dopamine transport back to the neuron, like would normally happen. It blocks the production of monoamine inhibitors that actually help break down some of that dopamine. So our brain bathes in it, and the neuron starts to get damaged because it can't get that reuptake. It also creates a variety of other neurological changes that increase not only the likelihood of dependence, but also movement disorders, cognitive dysfunction. We see hormonal changes that cause physiological consequences like heart problems. And then to top it all off, brain damage that results. In fact, we've got brain imaging that suggests that the damage is very similar to somebody with moderate to late stage MS with certain traumatic brain injuries. And by the way, very often this features a psychotic state that is virtually resistant to all antipsychotics and is relatively stable. So they are chronically, acutely psychotic. Terrifying. As we know, and hopefully know, one of the big psychotic symptoms, and just to be aware of, delusional parasitosis, the sensation of bugs under your skin. The physiological and neurological contributions of meth lead people to perceive bugs crawling under them. They pick at them. Sores don't heal because vascularity or circulation is reduced due to the meth as well. So be on the watch for that as a great sign. So what are the implications for treatment? Well, we've got to be doing ongoing screening for substance use disorder, not just a one-time thing. Even when it's not been present before, we should be doing this fairly routinely. Also, I think that there's implications for suicide screening because of the high correlation with SUD, and especially for some of the synthetics and for meth, the crash from those leads to an incredible depression experience, and that creates a big suicide risk. We've got to maintain vigilance and do good differential diagnosis of psychotic symptoms because that takes up a lot of our time, resource allocation, and we don't want to falsely identify somebody as living with schizophrenia when this is a drug problem. And just a reminder that substance use, even without dependence, still warrants our attention, still is worthy of, kind of kicking in our motivational interviewing skills. And just a final note, all of this is glib, but the good news is treatment does work. These two maps compare drug overdose deaths and suicide, and what we see is that there's a strong correlation. Darker areas on one map are darker on the other. But the good news is that when we look at like where the presence of treatment centers are, we actually see a flipping of that. We see that the higher the concentration, the darker the counties where there's more treatment, the lower the rates of overdose, the lower the rates of suicide. So that's all my time plus a couple of minutes. I appreciate your patience, especially with the failed video. I still get a little self-conscious when those things happen, but I'll press on. And I guess we'll kick it off now for questions.
Thank you again, Dr. Smith, for that very detailed and insightful presentation. I know I learned a lot just listening and hearing you go into some in-depth conversation there. So like Dr. Smith said, we'll go ahead and answer any questions that you all may have, in addition to any questions that may have been posted in the chat. So please feel free to start posting those now. I see we have one hand raised from Melissa. Go ahead, Melissa.
Yeah, hi. So I have a question about substance-induced psychosis. So we have been treating that in on psychiatric inpatient units, mostly because when they arrive at the ER, even though it might be substance-induced, their behavior requires containment because it is, they're psychotic and they're experiencing traditional psychotic symptoms that put them at risk for a number of things. Do you have a suggestion on something we should be doing differently? And like you said earlier, most substance use treatment programs are not going to accept someone with that level of behavioral risk. So we tend to hospitalize those folks until they clear. I just wanted to know if there was any other alternative that you've seen.
I think that for at least, the psychosis, the drug-induced psychosis, it typically is going to have a bit shorter of a window. So I think anytime we can create an opportunity for a little bit of a window, a little bit of space. So obviously we don't want to rely on the ERs as a holding place beyond, the normal time we'd expect somebody to be in the ER. But this might have bigger implications for, the growing number of crisis stabilization units that we have. I also think that, we're experimenting with other ways of getting certain PRN medications on board faster in individuals experiencing some of these things. And I think that that actually has a lot of benefit. And, anything we can look at as far as a way to kind of expand our ability to offer those PRNs could be really beneficial at avoiding some of that unnecessary care. But the truth is that right now, most of us are going to be limited by resources to having to hospitalize. And especially in clients who do have a psychotic disorder, they now might stay in that prolonged episode because of the presence of that substance. It may not have normally come on so quickly or at that time, but now it's here, and so it requires treatment.
Right.
What I will say, kind of just following that too, is that um, for meth specifically and that chronic use, the damage that occurs, even if it doesn't result in a what we hate to say is permanent, we can't quite say that it's unchangeable, but it's persistent anyway, psychotic state. The
Mhm.
one medication that does show some promise is, actually one that's in most of our formularies, and that's Zyprexa. So Zyprexa does seem to uniquely be able to address some of that substance-induced psychosis, especially from meth, in ways that certainly first gen meds simply can't touch. Also, I'd be remiss if I didn't say that because of the corresponding cardiovascular changes that can happen with some of these drugs, first gen antipsychotics might be contraindicated. So L-thorazine can all have cardiac exclusionary criteria. Obviously, that's out of most of our purviews of scope of practice anyway, but I think it's just worth kind of paying attention to that and having that information in case it's ever useful.
Thanks.
I know that didn't give you much hope. Like, here's the quick solution. Sorry,
Yeah.
Melissa.
Do you know if we wanted to ask the ER to wait, like what's the typical time? I mean, we've seen people who it takes like sometimes 3 to 4 days for their psychosis to clear, especially if they're like chronic meth users, which we often see, right? They come in with having used methamphetamines and they are very psychotic. And sometimes they clear and sometimes they don't. So I feel like we could probably get the ER to hold them for 24 hours. But
Yeah, I think beyond that, you're gonna get a whole lot of pushback.
yeah.
What I will say is that I think that, if it is substance induced, the half-life of the substance is going to tell us when we should start to see symptoms starting to abate. And sometimes it can be even useful to have, whether it's the ER, social worker or somebody from your own team, just checking in, doing some of the scales we have for assessing psychosis, just to see, are we seeing a reduction at all in symptoms? And to really impress on the ER staff the importance of having those PRNs administered and not letting big gaps go, because without the consistent coverage, I think what we see too often is like minimal effect, and we could see things sped up, I think, if we were providing those PRNs on time, 2 or 3 rounds.
I have one real quick if that's all right.
Absolutely.
Yeah, so along the same topic, I found this part very curious as well. Beyond methamphetamine, are there any other substances that also, I guess, if taken enough or that cause enough of that brain change, um, also have that same effect where some of the common medications would not work?
That's a good question. Yes, and because it's you that asked it and your work with older adults, I'll add a additional qualifier here. So what we know is that some of the synthetics that have kind of cropped up in recent years, I'm thinking of bath salts specifically, um, that has a very similar process where we're actually causing enough damage to like the dopamine system. And that is the system that the antipsychotic or anti-dopaminergic drug is going to work on. So I think a lot of the synthetics, that is one of the bigger risks. And then I think we have the effects of an aging brain that compound this. So as we get older, certain medications that we might have been able to tolerate well, maybe in middle adulthood, now are becoming contraindicated in late adulthood. So some of these drugs might actually limit on top of other limits, right? So the limits we have either because of a pre-existing health condition, because of the natural aging process, and something that's similar to somebody in older, later life, late adulthood. What we see is that chronic meth use, chronic synthetic use like bath salts and that, when we look at scans, there's this accelerated aging effect. So their brains start to look very similar. And that has, I think, some implications we haven't really, made sense of yet for how we might be able to treat this. Because we can treat the aging brain, but we have to go about it very differently and watch out for things like paradoxical reactions, where medication has the opposite of the intended effect because of these neurological changes. So, we usually talk about, meth more than any other drug, but similarly, some of these synthetics absolutely can do that. And then there's a lot we just don't know because they're too new and we haven't been studying it long enough. So, great question.
I have a question,
Yes.
if I may. I live in a rural area. Our hospital does not have like an observation unit. And one of the issues that comes up, especially if there's a patient who is not willing to stay in the ER, is that in order to continue to keep them there for the assessment, the petition, and then a clinical cert is initiated. And so now we have this process where there's this time frame where the second clinical cert has to be filled out. So having that 12 to 24-hour period of observation becomes very difficult, not only because the ER is full without beds, but also, now we have this time frame that has to be, we have to be mindful of. Any thoughts about what can be done to intervene at some point to?
Yeah, that's a tough one, because again, an ER is, really not an ideal environment anyway for somebody with psychiatric problems, a point that hospitals love to, especially nowadays, really emphasize. But it also doesn't change the fact that absent a similar type setting. And I think one of the things we're most hamstrung by right now is that there's, all this debate for crisis stabilization units, which if you're in a community lucky enough to have that additional resource, which is still rare, now there's the debate on whether you can use any type of restraints, including chemical restraints, which again, a lot of the PRNs to address acute psychosis can also be categorized as chemical restraints. So that creates, a new challenge. And so I think, unfortunately, in the short term, we're kind of stuck with There's no OBS unit. There's a finite number of beds. They're going to pressure to just move this case out of the ER. And I think, unfortunately, there's not much, we're really going to be able to do. Now, in the cases where there is like not immediately a bed available, for whatever reason, I think that's where we really need to be encouraging the ER to actually do the reevaluations to see if they're still meeting criteria. And I'm not going to accuse anybody of anyone, but I've worked in ERs enough to know that very often the review might be noted, but kind of once a disposition has been created, that's it. And you've had 15 different shifts of docs since that person was here, and nobody wants to touch it. That was that doc's decision. We're going forward. So I think sometimes it's, building that relationship with the ER so that they feel like they have an alternative discharge plan that's equally viable. And I've noted that a lot of ER docs just have a big deficit in knowledge of what a crisis residential unit is, what ACT services are, and why they're not just sending this person to the street, but they're sending them into a very high level of care.
Thank you, Dr. Smith, for answering those questions. So as we are a little over time here, I would like to encourage, if any remaining questions that anyone is seeking to pose, that we highly encourage you to go ahead and utilize that Q&A session with Dr. Smith. Again, the next available Q&A session will be Monday, March 10th from 11 to 12. So we definitely would like to direct you to attend those for any remaining questions that you all may have. Or as you start to think of any additional questions along the way, please definitely come in, pose those questions with Dr. Smith. So as we begin to wrap up and close out for this COP, again, we appreciate you all for coming and being in attendance and really just, gathering and sharing your thoughts and opinions in this extremely robust space for learning and education. So please do not hesitate to reach out with any questions or feedback that you may have. And we'll see you again next time, Friday, March 28th at 11 a.m. Have a wonderful weekend.